Can you able to see my slides, sir?
Yes, sir. We can see the screen. We can hear you.
Okay. Thank you, Tim Ferring, who gave me an opportunity to be here. And it's really a pleasure for me to be in this forum. And after hearing such wonderful lecture discussion from Professor Rema ma'am as well as Arvind sir, and we are here to take on with some interesting case scenarios that we came across recently. And for example, in this case, for a 45-year-old IT profession who had evidence of bloody diarrhea for a duration of time for more than 10 weeks, for example, who presented more than 7 to 8 episodes per day in the background of abdominal cramps, Chinese smells, and clinical picture more in favor of UC-like background, and the patient being initially treated with IV antibiotic support doesn't seem to show any major significant response. And apart from the no major systemic symptoms except for GI presentation, regarding the past, the patient had evidence of diabetes and no case of chronic smoker. The weight is almost in the higher side, BMI almost going with the obese cutoff, and alcoholic, and no significant family history of IBD. Apart from that, regarding the clinical examination, the pulse rate slightly in the higher side, temperature appears to be fine, and they run a sigmoidoscopy which showed evidence in UC endoscopic severity scoring that shows evidence almost on moderate severity based upon your vascular pattern, your bleeding, as well as your ulcerated lesions. Apart from that, they are done a stool culture, doesn't seem to show any major picture of your Clostridium difficile or CME like that. And your CRP slightly in the higher side, and hemoglobin is okay. Apart from that, regarding the management, so what is the basic things in this? See, this picture more in favor of moderate colitis. As of now, the UC severity, which is going almost in the range of 5 to 6. So this picture is going in favor of moderate colitis of UC. So what is the next management option? This is open area for us to discuss. Whether the patient to be initiated on AAC, whether the patient to be initiated on steroids, or whether the patient to be initiated on any IV medications, or whether the patient to be initiated on any budesonide, or we can switch over the patient directly to biologic support. See, even with the best of consultants, when you're going to tackle a clinical presentation for IBD, it's still a challenging issue in various clinical practice when you're coming across. See, right now, once a patient is diagnosed with evidence, we are not done in this picture. They are done as sigmoidoscopy. They are proven to be have evidence of distal UC and other presentation, but they are not done a full-length colonoscopy or even a small bowel surveillance study are not been done properly. But in this picture, when you're going to look into that, when you're going to initiate the patient on steroid, I mean, for example, 5-ASA, and for example, when you're going to start at a rate of around 2.4 to 4.8 grams per day, how far the patient is going to have a significant response that we need to have addressed. And once a patient you're going to initiate, whether the patient deserve add-on therapy with oral steroids or not, since the patient is having findings in favor of moderate colitis, that still we need to address. And moderate colitis is always to consider a oral steroid along with that. And to start the patient, as per the guideline, they'll be mentioning at steroids at a rate of around 40 milligrams per day. We are going to initiate, but usually hit the patient out with 40 to 40 milligrams per day for a period of first 4 weeks of therapy, followed by slow tapering. That's what the most of the thing, because most of the guidelines are coming slow initial tapering. But personally, what we like to feel rather than looking into every guidelines, hit the patient with higher dose, 40 milligrams per day, plus to maintain the titration for a duration of around 2 to 4 weeks of therapy, followed by slow tapering of steroid every 5 milligrams over the consecutive duration. That might be having a significant potential role. And once the patient is going to be on at a rate of around 5 milligrams, redo the picture, look for the evidence of histological changes, look for the evidence of clinical response, look for the evidence of endoscopic response, and see through that whether the patient is responding to the therapy or not. And if the patient is going to have a significant remission is going, then we can add on the patient with azathioprine support, followed by a slow, low dose of maintenance therapy can be given with your steroids. Along with 5 amino salicylates can be given. But this background, we can add the patient with oral along with a topical 5-ASA preparation is also ideal indication. So what is the major guidelines they have been recommending as per your ECO position statement or AAC position statement? All those things when you're going to look, what they're mentioning, start with 5-ASA and add on with the topical 5-ASA. If there is no response, add on with topical steroids. If still no response, add on with the oral or else oral steroid along with the patient we can consider for 5 azathioprine support along with that when you're going to look whether this kind of patient deserves biologics. Usually At this background, moderate colitis, we need to initiate the patient and we are not being assessed a full-length colonoscopy. Given though the infection criteria, we looked into that. Always we need to screen the patient as a whole to look for the complete clinical assessment, whether the patient deserves biologics, for example, your anti-TNF, or whether the patient is going to start on your anti-integrins. What are the molecules you're going to choose? You need to analyze the picture as a whole. That is what the clinical assessment I would like to point it over here with this basic outline of data, what we have been obtained. Always start with 5-ASA, maintenance dose of steroids, and initiate the patient on steroids with tapering dose of azathioprine. That's what the best of line of treatment to be considered in this kind of clinical picture, rather than directly switching over to a biologic support. So during this, induction of remission has not been due to job requirement, weight and diabetes impact, because systemic steroids, always we need to be very cautious because the patient already in obese parameter, so osteoporotic, and apart from the vitamin D, calcium deficiency, along with adrenal insufficiency, all these major significant systemic events of your steroids to be addressed. And even after that, for example, when you're going to initiate the patient with topical aminosalicylate, if the bleeding symptoms, if it is persisting even after that, of 2 weeks of duration, what is the next step? Whether we are going to, that's what, budesonide, is there any role? Predominantly in UC, that too in distal presentation in the background of your tenesmus as well as proctatic-like events, usually the role of budesonide is no major role, because in iliatic background, in the background of CD, that to moderate severity, mild to moderate, we can consider your budesonide MMX, and apart from that, no major role. Plan for biologics has what I've been discussed with you all already. And regarding the role of prednisolone, always start the patient at higher dose and slowly taper. Apart from that, and this is one case scenario what we came across. And another one I would like to show with in the background of pregnancy. Pregnancy is always a challenging event, because pre-pregnancy, counseling the pregnancy, and post-pregnancy, during the period of pregnancy, in the initial trimester, mid-trimester, late trimester, apart from that, during postpartum period, breastfeeding period, and apart from multiple other things you need to address. First, psychological support to be augmented, all these things to be addressed when you're going to look for a pregnant woman or pre-pregnant status, or who are in a plan to go for a pregnancy, all these things to be addressed. So this young female, almost in 28, being diagnosed with UC for the past 3 years. She was on the treatment with medications for UC. Now she is pregnant. Already she had delivered a baby. Now the second one being conceived. Now in second trimester, and one previous live birth is still on. She diagnosed, as I discussed. Now she had evidence of the UC-like presentation, like chronic diarrhea, or rectal bleed, cramp, Chinese mess, and all those things with weight loss. And she had evidence of anemia too in the background. So what is the next step we are going to choose? So when you're going to target with such kind of patients, what is the next line of molecule? That's very important. Whether we are going to start the patient on steroid, whether the patient already been on 5-ASA support, whether we are going to escalate the treatment with 5-ASA, or whether the patient is going to start on the steroids, or you're going to start the patient on biologics. In case if you're planning to choose the patient on biologic support, what is the best line of biologics we are going to choose? That's still a questionable issue. Among them, what are the various things that briefly we are going to take on with this discussion? So initial treatment, they have been given mesalamine, achieved significant minimal partial remission after 6 months, but she had mild flare up 1 year prior to the current pregnancy, which was managed with increased dose of mesalamine, as well as they're given some steroid enemas too. But in during this current pregnancy, the partner planned for IBD was in remission for months, but she was in mesalamine, as already been discussed. First pregnancy tends to be uncomplicated. As discussed, during this pregnancy, she remained stable for the first trimester, but no major significant flare-up. But 22 weeks of gestation, which means almost in the mid-trimester, she had again worsening of events in the background of worsening of your hemodynamic status, along with GI symptoms of clinical manifestations like your tenderness and all those things, along with the fetal heart rate, still maintaining reasonably well, almost around 150 beats per minute, which is reassuring. And clinically, the ESR is in the high range, slightly in the higher range, and anemia, which was almost in 10.2, CRP is also slightly elevated. Apart from the no major evidence of infections, and in colonoscopy, which showed evidence of distal colonic involvement in superficial ulcerations, which consistent with active UC, and fetal ultrasound normal development as of now. So what is the basic treatment plan? What is the safety of medication? As I discussed, what are the various biologics in case if you're planning to consider? The one biologics always we need to be very cautious when you're going to use in pregnant women is JAK inhibitors. tofacitinib or the newer molecule like your upadacitinib, even though it's specific JAK inhibitors, no major role to consider because it's still a contrary. Apart from that, your methotrexate, your your methotrexate as well as cyclosporine, no major role to consider during the pregnancy. And apart from that, all other major molecules. For example, in case of biologics, your Inflexi and Adalimumab, the two major molecules to be considered considering the clinical presentation in which the area of involvement will be more common. So Inflexi and Adalimumab we can consider in the management armamentarium. Apart from that, your vedolizumab as well as your ustekinumab also can be considered, but the papers of ustekinumab is slightly in the higher side when compared to Vedoli, but Vedoli is also having significant potential response to consider when you're going to tackle a patient with pregnancy. And as per the routine guidelines, you need to vaccinate and all those things. And very importantly, when you're going to use a biologic support, dual biologic, so many other things are still there to be addressed. And always JAK inhibitors, no major role. Steroids, high dose, 40 milligrams, initiating and maintaining the patient with tapering regimen, that's still accepted when you're going to put the patient on, even though if the patient are pregnant women. And 5-ASA preparation, topical as well as oral, definitely well accepted. And this is what the basic thing. Nutrition, iron deficiency is to be addressed, zinc deficiency to be addressed. Apart from that, in this kind of background, we need to look for folic acid. That's very common, even though in pregnant women, peripartum period, most of the time they'll be going to subject the patient with folic acid, no doubt about that. And all major nutrition deficiencies, we need to look into that. Apart from that, how are you going to monitor? So we need to assess the fetal well-being, whether the patient fetal well-being is growth or not. And apart from that, the psychosocial activities, whether the patient's psychological stability, we need to look into that. And apart from that, we need to look for the fecal calprotectin, your ESR, CRP, CBC counts when you're planning. Azathioprine also can be considered when you're going to use in the management guidance of pregnant women with IBD. You can consider. Apart from that, mode of delivery, very important. Mode of delivery usually mild to moderate. In this kind of background, moderate. In the moderate severity, we can usually go for a normal vaginal delivery, but there are certain indications. If the patient is having severe worsening of presentation, or if the patient is post-surgical, for example, in IPAA and other presentation, at that kind of background, we can go for surgical directly for a C-section, or if the patient has severe UC with more hemodynamic instability in other presentation, we can go for CS. And all these things, these are the criteria to consider. Or if the patient has a severe perianal fistulization, then we can consider the patient for CS. These are all the indications for which we can consider for CS directly, even in the background of IBD. But usually normal vaginal delivery will be the preferred mode when if the patient doesn't seem to show any major alarming worsening of events. And the mode of delivery, this monitoring as I've been discussed, and counseling, there is always psychosocial support. Apart from the serial monitoring, vaccination guidelines, you can vaccinate even the baby for the first, except for the live vaccines, March. The initial phase, as per the routine universal immunization guidelines, we can follow the babies also. Even for the mother, pre-conception period, we can go with the vaccination guidelines, but live vaccines usually you need to be very cautious. Apart from that, so counseling on the conception guidelines and all those things with serial monitoring, serial follow, definitely we can able to progress in this. And I would like to show one more interesting case slide. If time permits, I will wind up this and I will add one more case slide. Shall I do?
Sure, sir, please.
One more case slide, please.
Sure, sir. We have half an hour, sir.
Whether my slides are visualized, can anybody see?
Yes, sir.
Yes. This is a case scenario in which came across very recently. And this young female, the severe presentation, almost in findings in favor of UC, more severe, more frequency of stools, blood and mucus, tenesmus, and all those things. And no major significant extra GI manifestations. Apart from that, in the past, the patient doesn't seem to show any comorbids and social drinking, non-smoker, and no major significant family history. Regarding the hemodynamic status tends to be fine in this except for pallor. Apart from that, hemoglobin is in the range of 8, viral markers, X-ray, as well as all those things tends to be negative for this patient. And right now, the patient presented to us in the background of moderate to severe UC-like presentation. So we have started the patient like your basic antibiotic support with the basic steroids and mesalamine on day 1, the patient will be initiated. But day 6, as per True Love criteria, the patient's symptoms are not being much improving. So we have been categorized the patient with acute severe presentation of UC. So we have escalated the patient with hydrocortisone at the time. So we have been subjecting the patient to see whether the patient is responding to therapy or not. But day 7, the stool frequency is still more worsening in the background, the ESR, CRP, all those things going high. Add on antibiotic, we have without the steroids, and considering evidence of septic background, now the picture tends to be more, and there's still no major improvement. The counts are almost gone in the range of almost 24,000, and so in this kind of background, so the next step, what we are planning to choose, we need to look for evidence of biology. Since the patient no major response to steroid, your 5AAC, what is the next line of therapy we are going to consider? We need to consider biology. So what are the steps you need to do before starting the patient on biologic support? Look for evidence of infection, as what already Madam pointed out. So always tuberculosis, we need to screen. But even though if you're going to screen the patient for tuberculosis, are we fulfilling all the guidelines? Because few months before we came across a patient who doesn't seem to have any major clinical background of tuberculosis, that might be having a latent TB, and we have initiated the patient on steroid. Unfortunately, the young female succumbed because of the fulminant miliary events, and the patient collapsed. So this is what is happening in real life scenario. We should not mess. So how are you going to assess the LTB, a latent tuberculosis? It's still a challenging criteria. Whether the patient is affordable in India to work upon all, that's still a more questionable issue when you're going to look. And that's why I pointed out this picture. Whether you're going to do MAN2, whether you're going to do X-ray, whether you're going for your TB quantiferon, whether you're going to do your PCR-based assays, all still. But even though when you're going to look for your latent TB, how are you going to treat the patient? That's still. And there are various guidelines, whether you're going to use your INH plus rifampicin, you can go for 3 months of duration, or when you're going to use INH alone, we can go up to 9 months of duration. Now, some recent paper that we mentioned, even your rifampicin can be considered in iron molecule, every weekly titrating duration that can be considered. And this is all the basic outlines about your tuberculosis. When you're suspecting evidence of latent tuberculosis, we need to initiate the patient with steroids, initiate the patient with anti-tuberculosis therapy before considering the patient with evidence of either your steroids or biological support. This is one area we should not forget. Apart from that, what is the role of vaccination? Already been discussed. Your pneumococcal vaccination, your influenza guidelines, your meningococcal guidelines. And now, when, for example, if the patient is having, now, oral molecules like your upadacitinib is being well considered in the field. So when you're going to start on this kind of JAK inhibitor, specific JAK, so we need to start the patient on Shingrix. For example, your varicella zoster vaccination. So at the point when you're going to give this, the inactivated vaccine, we are going to choose. So all this vaccination guidelines we need to follow. That is very important when you're going to consider the patient on biologics, and look for the serial response. Once the patient starts on biological support, see through that whether the patient is responding to the therapy or not. Whether the patient responding to the therapy, it's well and good. If the patient doesn't seem sure, what is the titration? Are we adequately follow the dosage guidelines? Are we adequately looking into the serum and trough levels of these various molecules? For example, when you're going to use your azathioprine in the initial phase along with your steroids in this kind of background. So are we looking for all the patients with your GPMC levels and all those things? Are we doing into that? There's still a questionable issue when we are addressing, and how frequently we are monitoring the patient for leukopenia and other things, and frequent blood count and monitoring. All these parameters is still a challenging issue. That too, more financial burden to the patient. Is still more complicated issue to address when you're going to manage a patient with inflammatory bowel disease as a whole. This one point I'd like to highlight over here. Apart from that, in this patient, we have started the patient to, initially we have been treated with infliximab support to this patient. But what happened, unfortunately, once the patient been initiated with inflixi, the patient had generalized rash. We are not very sure, but there are some few case reports like SJS like presentation, Stewart Johnson like presentation with inflixi being reported. So we are not very sure what is the thing which has happened. So which made us to discontinue the drug after the period which the patient had minimal response with your antihistamines and other support, and minimal steroids and other support. The patient had responded to the therapy, and what we had desired, we have been initiated the patient with adalimumab. So as you all know, the initial loading dose 160 followed by you need to give at a rate of 80, and then we need to maintain the patient every fortnightly with 40 milligrams. So that's what we've been given at subcutaneous rate. And This patient we are given with dialysis support for a duration of time, almost around 2 years, in which the initial phase, if you're going to see the picture, the patient had more of pseudopolypoid lesions, which shows evidence of severe UC-like presentation. And in this, after 6 months of treatment, more resolution with minimal inflammatory cascade is still happening. Apart from that, the significant response to therapy being developed, and over a period of almost around 2 years, the patient had significant response in which the inflammatory cascade has almost gone, and the patient colon tends to look like a normal one. This is what happened for the case which has come across for a duration of time. So, with this background, we all know that the basic outline, as we already discussed, the proctitis, left side. So, first thing is identifying the case is very important. Tackling whether we need to recognize whether the presentation more in favor of IBD, UC, or CD. And in case of UC, severity indices, all those things, and the extent of the disease, as per your Vienna guidelines, as per your UC guidelines, you need to see whether the extent of disease, whether the patient is having proctitis or left-sided or extensive, and based upon that, we need to decide whether the patient is on topical or oral or intravenous, or whether the patient we need to give up biologics or oral molecules, or add on to that your anti-integrins. And various pathways, whether so still we are having more challenging issues for this, mild, moderate, severe stool frequency and all those things. But why I would like to point out this picture, once the patient had evidence of ulcerative colitis, that to severe ulcerative colitis, when you're coming across always, what do you mean by the criteria for severe ulcerative colitis? The few points. Once the patient is starting on steroids, if you're not going to respond, three major parameters: your clinical markers, your biochemical markers, and radiological markers. If the radiological point to the dilatation of colon more than 5.5, ESI, if it is going to be more than 75, and the temperature of body tends to be in the higher side, along with stool frequency in clinical background is still worsening more than 12 per day, the risk of colectomy is almost going around 55% as per your Oxford criteria. This is what I would like to point. So once a patient comes into the criteria, we need to choose whether the rescue therapy with your inflexible